Good for you, Chelsea. Keep talking.
Oh, you know, once I start, I'll never stop. So we want to encourage that.
And I'm just going to test, can people hear me?
Yes.
Awesome. Thank you.
Again. Okay. So let me send a note to Ed.
Providing care for a child.
Oh, Ed's on.
Okay.
Right.
Hi, Ed.
Hello.
Good. Okay, we can hear you. Will you be sharing video as well today?
Yeah, I can turn it on. Just give me a minute.
I just want to check that out. Perfect. And Marie, did you want to go over housekeeping before we let the attendees in, or do you want to do it once we're in?
I was just going to do it after, or, I mean, I guess you want,
That's fine.
The housekeeping, that might be easier. What do you think?
Sure.
So good afternoon. I'm just going to go over a few housekeeping items. If you're not speaking, please mute your microphone to eliminate noises and distractions. Likewise, you can go ahead and turn your camera off just so it's not so distracting and preserve bandwidth. And then if you have any technical difficulties, please use the chat function or email Josh Shapiro or Jamie Elliott. And I think they will put their email addresses in the chat or and then Jamie will be our timekeeper. And I think if you've been on the last few minutes, you've known that he will be sending you a tone, and it is very soft tone, so you shouldn't be alarmed. At the 5 minute, 1 minute mark, and then at the conclusion of your time. And then as far as this will be repeated during the question and answer period. During that period, judges will have the opportunity to pose questions directly to the presenter. You can also put the questions in the chat, the Q&A, and I'll look for them. To prevent multiple judges speaking at the same time, I'm going to be calling on the judges individually, one at a time. And then just at the conclusion of today, we're going to, after all the presentations and Q&As, we're going to ask all the attendees except the judges to exit the Zoom room. And please do it as quickly as you can so we can move on to the next portion of the day. We'll announce the final winner on December 14th. The winner will be posted on the Grand Challenges website, and then HRSA will also make an announcement via social media. And we will be communicating with all the teams prior to the posting. And finally, we're going to be sending all the teams a relatively brief survey after today. And we're going to ask you to please complete it by December 10th. We really appreciate you answering the survey because we're going to use these responses to help us improve our challenge process. And then just you know, I just want to say, which I'm going to say again later, that I really wanted to thank you again for all your efforts and really how much I enjoy working with all of you. And so we can go ahead and move on to the main session, okay?
I'm going to open it up right now, Marie.
Yeah, people are asking if it started. Jamie, is it ready to go?
Yes, ma'am. We are live.
All right, great. Good afternoon. Welcome to the Phase 3 demo day for the Care Coordination for Children with Special Health Care Needs Challenge. I'm Marie Mann. I'm the lead for this challenge. This afternoon, we're very fortunate and privileged to have Laura Kavanaugh, Deputy Associate Administrator for the Maternal and Child Health Bureau, join us to provide us with some remarks. Laura?
Thank you so much, Marie. I'd like to join Marie in just telling you how happy I am to be joining you for this welcome to the Care Coordination for Children with Special Health Care Needs Challenge. You've made it. It's now Phase 3 demo day. You've all come such a long way since the beginning of this challenge in 2018 and have met many unanticipated challenges along the way, even including the COVID pandemic. We know that for many of you, the COVID response has impacted your day-to-day work. We so deeply appreciate your flexibility and your commitment to this challenge, given so many of those competing priorities over the past year. At MCHB and at HRSA, we're committed to improving the health of America's mothers, children, and families. The majority of our funding portfolio comes through in grants and contracts to carry out our mission. But more recently, we've embraced the challenge as a mechanism to complement this portfolio. We're incredibly excited about the potential of your innovations to help us meet our mission, and specifically to support the coordinated care for children with special health care needs, ultimately improving health outcomes for these children and their families. We want to share that while only one winner will be chosen for this challenge, you all have succeeded in this project. We'll do everything we can to help support your innovations to be sure that they reach children and families throughout the United States. It's been such a pleasure for MCHB to engage with you through this project, and we thank you so much for your commitment to advancing the field through your innovation and through your energy. Good luck. Thank you.
Thank you very much, Laura. As Laura indicated, the intent of this challenge is to support the development of innovative technology-based solutions for improving the health and of children with special health care needs and to lessen the burden on their families. And specifically, we imagine improved care coordination and planning by the exchange of data from different sources organized in a single user interface whose access would be controlled by the child's parent or guardian. And as we certainly have come a long way since the start of the challenge, about 28 months ago. And we are grateful to the teams for certainly your dedication to this project and to your innovation and certainly agility throughout the unexpected events of 2020. We could not have gotten to this point without the effort of our 7 expert advisors who served as mentors for the teams. And hopefully a few of them have been able to join us because they really provide invaluable support to the teams along the way. We want to thank also our 3 federal judges, Ed Lomaton from the Agency of Health for Healthcare Research and Quality, Tom Novak and Liz Polinajar from the HHS Office of the National Coordinator. And they have been present throughout this process. They have shared their expertise and certainly time with us. And then finally, I give my gratitude to my MCH and CCC colleagues who have really contributed much to the success of this challenge. This afternoon, each of the 4 finalists will have 10 minutes to pitch their innovation. This will be followed by 10 minutes when judges can ask clarifying questions. And before, again, we just as a reminder, I think if you're not presenting, please mute your microphone so that to minimize noises and distractions. And then again, at the conclusion of the event, we're going to ask all attendees, except the judges, to exit the Zoom room as quickly as possible. We will announce the final winner on December 14th. And the winner will be posted on the Grand Challenges website. And HRSA will also make an announcement via social media. And then we will be communicating with all the teams prior to the posting. Before we move, just again, for those of you, we can't say enough how much this has been a wonderful, exciting initiative for the Bureau, for my division, and certainly for me. And as been said, again and over again, that MCHB and HRSA are very proud of everyone's work, and that we consider all of you winners because you have all accomplished something exceptional. We will now move on to the presentations. The order of the presentation is as follows. Speak Health from Nationwide Children's Hospital, my PHI from PHI Limited LLC, Care Map from Boston Children's Hospital, and then Montana Pediatric Medical Passport from the University of Montana. Speak Health, you ready to go?
Hello, sure. Let me share my screen.
Emma, do you want to introduce your team members, or will you be doing that during?
We'll do that at the end of the slides. All right. So let me stop. Hold on. Sorry, I need to turn off the video. Okay. So I'm going to share again. Sorry. Please let me know if you see the screen. Can you see?
Yes.
Perfect, perfect. All right, hello everyone, I am Emre Sezgin. I'm a digital health scientist at Nationwide Children's Hospital. And it is our pleasure to be here today to present our project. And we are going to start with a 2-minute video of introducing Speak Health. This is the, oh, sorry. I think I should do this, all right.
Providing care for a child with special healthcare needs can be especially challenging. Caregivers often need a network of support. This can consist of multiple family members, in-home nurses, medical staff, teachers, and others. It's important for caregivers to keep track of a child's healthcare events and treatment regimen at home and to share this information with the entire support network. Currently, many keep a diary on a paper notepad, a calendar attached to the fridge, or various smartphone apps with limited functions. This makes it difficult to share and hard to find information when needed. We created the Speak Health app to provide caregivers a way to document and search a child's health information with ease, enable sharing among all stakeholders, and empower everyone to provide the best care. Speak Health integrates with MyChart and gives caregivers the ability to track their child's health events and response to treatment by allowing them to speak their notes into the app. Using a HIPAA-compliant AWS backend, voice entries are transcribed and saved as text notes, providing convenience to busy caregivers who often have their hands full. Entries can be easily searched and organized into reports, so the important information for the next clinical visit can be accessed easily. In addition, with the help of artificial intelligence, SpeakHealth will compile data from note entries in a way that gives physicians valuable insights into how a child is responding to treatment. All entries and reports can be made available to anyone in the Child Support Network. Following our initial work, there are many paths to sustainable future development for SpeakHealth. This includes commercial options with the support of Nationwide Children's Hospital's Office of Technology Commercialization. We believe that SpeakHealth has the potential to be a critical tool for caregivers, their support networks, and medical teams on their journey to achieve best outcomes for children with special healthcare needs.
So in the phase 3, we have a number of improvements with our SpeakOut app, as you saw in the video. But our phase 3 efforts were significantly impacted by COVID-19 as our institutional resources focused on supporting telehealth deployment, and IRB was overwhelmed with the COVID-19 related research projects. So as face-to-face interviews were no longer allowed, we have to change our approach to engage with research participants virtually. But as of today, we recruited 41 parents of children with medical complexities to test SpeakHealth, and 21 of them completed a 2 weeks real-world trial so far. And we also submitted the feasibility manuscript in addition to the already published protocol paper. Now let's take a look at what we have achieved in phase 3 through an example. First, we improved the accuracy of speech recognition and transcription through a scalable AWS medical transcription tool, which specializes in accurately capturing and narrated medical terms. In order to reduce the information burden for the providers and caregivers with all these notes, we used a custom-built NLP algorithm to extract meaningful and relevant information utilizing medical vocabulary such as SNOMED. As you can see in the slide, we are able to capture symptoms and conditions such as seizure and fever from the notes and turn them into a structured form. In addition, we capture medication, dosage, disease-specific attributes such as nutrition, treatment, and bowel movements out of the free text notes. To make this valuable information conveniently accessible and digestible, we created an interactive dashboard to present the information. It is a data visualization tool for caregivers, patients, and providers, and the data can be filtered by time, symptom, drugs, or other attributes. Users will be able to see the changes over the time with a timeline graph related to these attributes, such as changes in bowel movements over a 3-month period. Finally, with an integrated alert system, providers and caregivers will be able to create an alert as a reminder or a warning about the changes of these attributes, such as increasing number of symptoms or reduced medications. So physicians, nurses, and care coordinators will be able to access the calendar dashboard through a link on an EHR system. They will be able to observe short-term and long-term changes in conditions and symptoms and medications from this dashboard. And it will be also available for caregivers through SpeakOut app. So our real-world testing study was designed to be a 2-week trial of SpeakOut app with the parents. The graph at the left side shows the medical conditions of children of recruited parents. SpeakOut has been used in different formats such as seizure tracking, pain diary, medication, nutrition tracking, and which can be also conveniently translated into enhancing clinical decision, care management, and care coordination. So results were promising as 78% of the participants found the app useful and easy to use, and SpeakOut have also changed at-home health note-taking behavior positively, as 43% of the participants reported. And you can see a comment of a parent expressing the app utility in the slide. So looking at the data, we observed that participants were able to keep around 120 notes during the study period, and they created 17 reports out of these notes, which could be used in clinical visits. You can see another sample note in the slide. And also, we need to note that 90% of the participants mentioned that a voice-enabled app like Speak Health could be useful at home care during pandemic. And this will definitely add the value to Speak Health as a potential remote monitoring tool. So how can we make Speak Health to be sustainable and accessible by the community? So at first, we are aiming to disseminate through local channels. Nationwide Children's Hospital has an official app which has been known and used by our patients and caregivers. And it could potentially house and support Speak Health. In addition to that, we will, with the support of the Office of Technology Commercialization at MCH and Rev 1 Venture Capital Funding in Ohio, and also our partnership with AWS, Google, and Microsoft, we can potentially commercialize or license Speak Health and AI components. Alternatively, we can SPR and NIH grants could help to scale up the implementation and support the evidence-based research. And finally, based on the path we choose, we can make the tool and source codes publicly available to be used by other health institutions and researchers. With that in mind, we have identified potential beneficiaries that we can partner up to make Speak Health available for a broader audience. Some of these beneficiaries are Franklin County, Partner for Kids, and Department of Health at Ohio. So if we receive the final prize, we aim to improve AI and app functionalities, such as development of NLP algorithms for other disease groups, including new features for the app, releasing in multiple digital platforms, and incorporating FHIR APIs and other standards. In addition to that, we will improve accessibility and to create networks to disseminate and test Speak Health with larger, more heterogeneous cohorts. And we also will explore beyond complex care, such as adult populations and underserved populations, to increase the utility of this app. So we would like to thank you for listening, and here's our list of great team members and supporters that we are extremely thankful for. And thank you.
Thank you for a great presentation. We'll now move to the question and answer period. Are our judges, could you turn on your camera? Emrit, could you close your presentation?
Okay, all right, okay.
Great. Let's see, there's Liz, Ed, and Tom. Let's start with, let's see. Ed, do you have any questions?
Sure. So thank you very much for the presentation. That was great. I do have a couple of questions. One, does the voice transcription is it able to transcribe more than just English? Are there other languages that are supported?
Currently, we haven't tested that, but there's a potential to expand through other languages such as Spanish. And it is kind of limited to what AWS provide, but actually AWS has, I think, 14 other languages supported, but we haven't had a chance to test it with the parents.
Okay, that relates to sort of another question. So the voice transcript depends on AWS sort of translation.
Yes.
You mentioned later, or later, maybe in terms of future work, does that voice transcription serve as, I guess, depend on how good the translation is with respect to the condition? So, for example, if you are piloting among kids with epilepsy, Do you have to train it to understand words that may come from different conditions?
That's a good question. AWS Medical Transcribe tool has most of the terminologies that can be used in medical terms. So probably, per our testing, it can capture better than the regular transcribe tool. But in addition to that, we are using our own in-house NLP algorithms to find and detect these terms from the free text notes transcribed. And we are kind of using it to turn into a structured form. So such as for your example, for epilepsy, we can create our own vocabulary to capture this important information through these notes. Even though we cannot handle the AWS part right now, we have this ability at the free text notes.
Great. And then thank you. The other question I had was, you had a good on your slide example of what might be spoken in. I wondered if you could talk even a little more about, in the pilot so far, what's typically been sort of spoken into the device? What do people usually report in? I guess the follow-up there is it mostly for them to remember later, or is it mostly for them to inform their clinical team because that's the easiest way of entering it, or maybe it's a bit of both?
Yeah. So when we look at the data that's been collected in our servers, some of them were reminders for them to remind medication refills and creating an appointments for their kid. And some others are actually tracking and capturing the at-home events, such as like when epilepsy. We had a couple of epilepsy patient parents, so they were actually capturing when the kids had a seizure. So they were narrating that that he or she, the kid, leaned forward. It took like 10 seconds, and the kid stand up, played again like nothing happened. It was really quite an extraordinary experience for us to observe these notes and collected at home. We are still processing all this information. Since this study is still going on, we are still recruiting, and people are actually currently using the app. But these are the main themes that we observed from the notes so far.
Great, thank you.
Thanks.
Tom?
Yeah, similar to Ed's comments, and I think when we were reviewing all these, we understand natural language processing, and sort of to us is sort of a known quantity. But I do think it's maybe a bit of a critique for your pitch deck and your approach, that you sort of need to sell natural language processing, like to the average person. I think the average person still doesn't appreciate the sort of accuracy of it. So it's sort of describing the quality, the quality improvement step, like this sort of how you QA'd what was spoken versus what was ordered, and sort of that verification would be helpful to the audience, because I don't think it's widely appreciated how accurate it is. I know it's AWS, but still your audience won't always be familiar with sort of the rigor of that. And I think adding a little more meat on here about, here's the QA steps, we did this analysis on what was said, what was done, even if you're sort of cribbing some of the accuracy stuff from AWS, because they probably have done, I'm sure they have a lot of stuff you can draw on from them. I think that would be generally helpful. So maybe more of a comment, I guess. But I also didn't see that in the presentation, any sort of discussion of the QA steps. So I would sort of ask if there was some, and if there was some, it should be included. I'm going to assume there was some, though.
Yeah, thank you for your comment here. So for the accuracy measurement, we haven't done accuracy measurement with the data that we have right now. It is because last month we started this study and still going on, and the data is still accumulating, so we didn't get our hands on. But we did some measurement with the preliminary data that we collected through our testing. So we observed with this testing 75-80% accurate, but it also depends on the condition and the environment that they're talking, and other factors that kind of limit the capturing of the voice. So we cannot speak for sure what is the current accuracy rates with the data which we collected. what we are going to do is we are going to listen these audio recordings and also compare it with the transcribed data so that we'll have a better understanding how AWS is performing with this data collection. But in our previous prototype testing phase, we got some feedback from the users when they're testing in-house, like through face-to-face interviews. We observed that AWS may have failed in a couple of instances that capturing medication names, like albuterol was captured like computerol, and this kind of recovered with the medical transcribe. But we also get this feedback from the users that they are in a way fine with correcting a couple of errors in the transcriptions instead of having to write all the notes that they need to keep through keyboard. And that was kind of a positive reinforcement for us that method can work actually with a couple of errors still. Thank you.
Yeah, thank you. Liz?
Yeah, hi.
Hello.
My questions are more around the experience, how I guess the data was used as between the families and their providers. So like ease of use and user experience around use of the graphs, I guess you would call them. And just if you could elaborate a little bit more on that.
Your question is about the dashboard?
The dashboard, right,
okay,
exactly.
Okay, perfect. That dashboard is a product of our the feedback from the providers and our mentor and also the parents. So when we use this structured information translated into this dashboard, it is actually not in production. It's a mock-up right now, and we try to make it pretty useful for all of the stakeholders. And in that regard, we created this 3 categories. I can actually share my screen and kind of quickly go through that. Okay, so this is the mockup. And for this initial mockup, we created with symptoms like symptoms, drugs, and bowel movements. And in this case, we were specifically focused on cystic fibrosis case. And in that dashboard, people can filter out what they want to see, and they can engage with the specific dates and see the drugs or symptoms or bowel movements related activities captured. And they can also see the actual notes taken from that date. So as I told you, this is a mock-up, and these are all like fabricated notes. We haven't rolled it out for the actual notes, and this is going to be our next effort. But so far, this mock-up kind of received good feedback to engage with this kind of like a huge information, because otherwise it is hard to read all the notes being taken at home, especially for the providers. And this will definitely reduce the burden to go through the patient notes. And it will create, this is like also a mock-up graph, and we will also include and implement a long-term chart to show how, let's say, drug intake changed over the time of 3 months or a year.
And did you get feedback though from providers? You said you got feedback on providers as well on the visualization, of whether or not that was their perspective on that?
First, we interviewed 15 providers at the prototype phase. This is based on that. And in this third phase, we only talk with 1 or 2 providers in our stakeholder group to get their feedback. And this also includes our mentor. She's a physician as well. And through their feedback, it received like a positive, the providers were positive through such a dashboard. Especially, I think we talked with our chief physician at our complex care clinic, and he's one of our stakeholders, and we received like a positive feedback about this dashboard, and we are planning to improve that for the further production stage.
Okay. And so just one more clarification. So the data that is exchanged between the mobile application and the EHR, that includes, is it all the notes and as well as and then, so explain a little bit, what is the data that's flowing between the app and the EHR?
All right. So there's a two-way flow with the app in the EHR. One is getting through my chart, it is the app for Epic EHR. Through my chart, we'll be able to pull all the patient data to demonstrate to parents about the following appointments and the other information that they may need to see. And at the other side, when they keep their notes at the back end through another channel, these notes are stored at AWS, and we will connect from AWS to the dashboard, and dashboard will be linked to the EHR, not actually deployed information per se. It is still be kept in HIPAA compliant AWS servers, but there will be a link for providers to click and engage with the dashboard and see the notes. We are not actually right now pushing all the notes to the EHR.
Okay, so basically AWS is what is serving up the visualizations.
Yes, yes.
Okay, thank you.
Thanks.
Well, thank you very much. I think it's the end of this team's presentation and the Q&As. We're going to be moving on to the next presentation, MyPHI.
Thank you, Maria.
Thank you so much. Can you hear us? Such a pleasure to see you.
Yes, we can.
Okay, thank you. So we're going to go ahead and share our screen. All right. Well, thank you so very much. It's been a wonderful journey. 2 years ago, we were just a couple of colleagues trying to solve the problem of patient-controlled health data sharing. And now 2 years later, we've been able to build a robust product, and that is being widely adopted and truly owing to this opportunity. But why don't we take a step back to see what we're trying to solve for? Let's watch this short video.
Mrs. P is a busy mother of two. Her 10-year-old son Mike is in the 5th grade and has been diagnosed with ADHD. Mrs. P often needs to share school information with Mike's doctor to help the doctor understand how Mike's treatment is working. It usually takes days or weeks, multiple phone calls or office visits in the middle of the day to get any information from the school to the doctor. When Mike sees the doctor, the paper care plan does not help either. Mrs. P is likely to misplace it and end up not being able to share it with the teacher. The teacher and the doctor cannot work together because it is hard to get information from one system to the other. Mike is not doing well. His grades are failing, and his behavior is out of control. Mrs. P is frustrated by the multiple reports sent home by the teacher and logged onto the school portal. If only Mrs. P could send Mike's school behavior information to the doctor before Mike's next visit, the doctor might better understand how poorly Mike is doing. Mrs. P has heard of MyPHI at Mike's doctor's office. MyPHI is a HIPAA-compliant cloud platform which will help bring and secure all of Mike's health and school information in one place. With MyPHI, Ms. P will be in full control of Mike's data, which MyPHI will organize and make it easy to share with other people. Mrs. P decides to give it a try. In a few easy steps, Mrs. P registers Mike on MyPHI. She enters Mike's health and school portal information on MyPHI. Within 3 minutes, MyPHI has worked its magic. Mrs. P can see Mike's health and school information side by side on MyPHI. The information is easy to view, download, and share in a few simple clicks. Mrs. P can even upload a picture of Mike's most recent ADHD evaluation from her phone into MyPHI. Mrs. P can also easily customize what she wants to share with the doctor or the school teacher. The doctor receives the reports and finally gets it. Mike's medications need to be adjusted, and he needs more behavioral support at school. The doctor puts the information in Mike's care plan. MyPHI automatically uploads the new care plan, and in a few simple clicks, Mrs. P sends the care plan to Mike's teacher immediately. The teacher now gets it. While Mike's new medications take hold, the teacher will send Mike to a school behavior counselor and change his sitting in the classroom, giving him more time and less distraction to complete his classwork. Mike's behavior is improving. He is more focused. The teacher sends home more positive behavior reports. Mike is finishing his classwork and his grades are getting better. Mrs. P shares Mike's grades and behavior reports with the doctor in a few easy clicks. The doctor is happy. Mike is doing better and does not need to see the doctor very often. Mrs. P is less stressed out. A few easy clicks are so much better than countless hours on the phone and driving to the office. The teacher and the doctor can now share information more seamlessly, which we find highly compelling.
So, whether it's Mike with ADHD, poorly controlled, or AJ with poorly controlled asthma, millions of kids are not doing well in our schools and are likely failing due to the fact that health information is not being coordinated between school nurses and doctors. And the problem is poor care coordination is costly and deadly, with millions of school days missed and billions of dollars lost because of health information being locked in disparate systems. All the stakeholders, however, have stakes into seamless data sharing, which could save lives and money. So the current status is a disjointed system in which the mom, the caretaker, has to coordinate care manually across different systems. But then the mom or the parent signs for MyPHI one time, and then MyPHI takes over and can update the data, organize the data for the parents. And with this patient control system, the patient owns their information, can share it with whomever they want, and gain some insights from the reports that MyPHI produces. So since the last time we met, we've gone from a minimum viable product to a fully functional product that's highly adopted and is adding value despite the disruptions from this pandemic. We've been able to engage one large urban school system, the Fort Worth ISD, with whom we have an MOU, 5 health systems, up from 2 last time we met, 2 Medicaid HMOs. We've been able to pull social media data, to pull insights from it, to develop a risk prediction model that's helping our parents and empowering them to make decisions for their children in terms of whether or not it's safe to return to school in this COVID pandemic time. We have over 1,200 users now. 239 of them have been established for over a month and a half. 127 of them are students from the Fort Worth ISD. So our team really has been responsive and innovative in the way we've adapted to the challenges. So we're going to go ahead and give you an update of what the platform looks like. Ivailo, over to you.
So as you understand, currently we have about 1,200 users all over the states and actually around the world. Here you can see the login screen. So we're logging in the system. So whenever the user is logging in the system, we can create several different people in our system. And for every person, we can have different profiles inside of them. We developed support for multiple languages. One of them is Spanish. And also here you can see how we create a new person. And when we enter in a person, there are a lot of things we can do with the person. But one of the things I want to show up is that one person can have multiple profiles, which means that we can download health and school information from different sources, and the user can put information by themselves. And here you can see how a profile looks like. And as we stated, the user can decide to share or not to share different portions of the profile by clicking on the visibility settings. And one of the important functionality we developed is to send temporary link. With this functionality, the user can decide to share their profiles to whoever they want in a very secure manner. And also the person can decide what is going to be the life of the temporary link. By default is 48 hours, and the user can decide to share or not to share their information with Fort Worth ISD, one of our big partners right now. Here you can see how we add connections. So in order to extract the information for the user from an external source, the user simply has to say what is the source and to enter username and password. One of the very powerful functionalities we developed is the export summary. In the export summary, the system gathers together all of the profiles for a single person, all the information they're entering by themselves, all the information we're extracting from different schools and hospitals. They can share this information again with whoever they want. One of the great things we developed is the timeline. This is a really great view in which we're arranging by date all the information we have for a certain person. So you can see the laboratory tests, the medications, the different diseases, the date of birth for the person. And we received extremely positive feedback about this functionality from the physicians who are working on. Just imagine that you can see all of your health history in a timeline. It's a really powerful tool. And another thing we do is we're extracting all of the zip codes associated with the person, and we run it with our risk prediction model, so we can say what is the COVID risk score for every zip code associated with the person by using social data from Facebook and Yahoo. They are doing surveys every day. And also we have a feedback tool inside our platform. Actually, our users were very active, so we received a lot of feedback. So having said that, we're going to be back to the presentation.
Thank you so much, Ivailo. So that's the progress we've made, and you can see that we're having a growing user base, and our users have a lot to say about the platform. We have about 84% of folks on the platform actually are using my PHI to share data, at least over the past month, and 94% would highly recommend it because they find it helpful. The Fort Worth ISD, our largest school partner, is a capitated urban educational system with over 84,000 students, and they serve a majority low-income students. They have a high population of students with asthma, yet they have very little visibility in who actually has asthma before they have issues at school. So they're engaging us to provide them that data insight by pulling information from the parents and giving it to them, in addition to the COVID-19 risk reports that we're sending to them. So we're currently running a 5-school pilot that's touching 2,400 students, which is going to be expanded as soon as the pilot is completed, with a potential for saving them some substantial amounts of money. So our goal, if afforded the win on this phase, is to expand the platform, roll it out on a larger scale to benefit many, many more parents with issues. We have 150,000 students that we're aiming at, hopefully looking at the Fort Worth ISD, other ISD, and expanding in the healthcare system. We really appreciate your support, and we wanted to conclude with a statement from our Fort Worth ISD partner.
I'm Toby Jackson, First Vice President of the Fort Worth ISD Board of Trustees and Executive Director of Fort Worth SPARC. 8 years ago, SPARC determined asthma was the #1 reason for chronic absenteeism in Tarrant County students. The challenge, however, going system-wide proved to be communication between teachers, parents, school nurses, and medical team. Upon introduction to Dr. Pengetzny and the team at MyFi in 2019, we found technology and a team capable of addressing our challenge. Working to maximize each student's continuity of care, our already overburdened school nurses spent enormous amounts of time trying to reconcile the needed information for students with asthma, ADHD, or other chronic conditions, simply because coordination between healthcare entities, parents, and schools requires vast amounts of time. We believed the solution was paramount, and with the MyFi team, it became imminent. MyFi fills in this very substantial gap by making it easy for our parents to share health information with our school nurses and physicians. SPARC and Fort Worth ISD are exceptionally proud of our partnership, which is in its infancy with MyFi, and we need more support so that we can continue to look forward to completing this pilot and expanding MyFi's technology and services to support each of our 80,000 students and families equitably. And that is the goal: equitable support locally, regionally, statewide, and building a national model. We'll do it. Please give us a hand. Thank you.
Well, thank you so much for listening. We are very much grateful and open to questions.
Thank you. Let's go ahead and start with Tom.
Sorry, there's competing voices in my room. I would want to ask, I guess, 2 things. One, to what extent are you coordinated with the CMS Patient Access API? Because that would go a long way. since it's already written, it's already out there, it does a lot of what you're trying to do. And then second, and you're maybe already aware of this, or I assume you are, but it's also, I think, worth flagging for people who are sort of tentative about entering this area, is the extent to which you reviewed FERPA to make sure that nothing you're doing is sort of contrary to FERPA, or that you've sort of considered all of the sort of permissions required, and that your workflow is, you say you're HIPAA compliant, which is great, but you also, I think, should early on say, and we're FERPA compliant. And if you're not, you should, confirm all that.
I totally agree. No, to begin with the second question, yes, we are HIPAA and FERPA compliant, and we work with the legal team from the health and the school systems to make sure we are abiding by all the laws, regulations, and local policies. And as for the patient-facing API, that's one that we are actively working to get into. The only slowdown right now is that it's not necessarily widely adopted as of yet, but we are totally monitoring it, and we're adapting to pull that in as soon as it comes through, because as you know, right now we're using a technology that pulls the data on its own, but with an API, it's just going to be much more organized, and we're ready to pull that in. Our process is very much, let's say, data blind. So it doesn't matter the kind of data, we receive it. So we are highly interoperable. That's a great point.
We notice that many of the school systems we're currently working with, they are using very old systems. So because of that, we had to develop this general way to extract information, because even if API is available, it is going to be likely available in years. And we're very much open to that, because it's so much easier to read from API.
Agree. That is, we're trying to make sure that we adapt to every system. Not every school system is going to have something sophisticated. Not every health system is going to have API available. As soon as it's there, we'll pick it up. But for now, we're adaptable to any platform. A great question. Thank you, Tom.
Great, thank you. Liz?
And my question is more, I guess, on the aggregation of the data from different sources. I'm just thinking about, sharing the data with the schools, and how, are you pulling in from, I think I saw labs on there, meds, maybe the child is seeing various specialists, the specialists might be on different levels of technology. So wondering how you're aggregating the data and how that is how that's going, that experience. And then a second question is, so that's what would be shared with the schools. Wondering as well if any information, if you could explain about information going from the school back into healthcare.
Yes, so let me take the second question. I'll let Ivilo speak to the first question. But the second question, yes. So actually information is going from school back into the health system. So we're pulling data and pushing data through the patient portal. So everything the patient can do to push data to the health system, we are currently doing it as well. For instance, a parent can upload a Vanderbilt scale for ADHD from the school system and put it straight into their health, through the my chart, for instance, into the EHR for the doctor to see, and vice versa. The patient, and one of the biggest things that patients have been sharing are immunization records. They can pull immunization records from the health system and share it with the school, and vice versa. Pull it from the school system and share it with the doctors. And by the way, the doctors somehow, despite the entire sophistication, the things that seems to bug them the most, pediatricians, is not being able to get immunization records. And so we typically have to go through the school system. I'm a pediatrician myself, and it is just a nightmare. So just being able to get it straight from one end to the other. And we have one functionality that's important, is that if the patient signs the consent by just switching one button, then my PHI can actually automatically send out some health information for them. But they do have that visibility setting where they can go and say, hey, I only want you to share my immunization records and the labs from these days, and that's exactly what we're going to share. And I'll let Ivilo speak to the first question about, pulling data from different rudimentary systems and organizing them.
Yeah. The sharing part. So share information in several different ways. So the first one is by email. So if the person enters an email in our system, we can share this automatically or on demand. And I'm going to give a little bit of trade secret how exactly we're pushing information into the health system automatically without the person entering into the MyChart, for example. So MyChart has functionality to send a message to the physician. And actually our system is using this functionality to fill the message for the user and to send it automatically. The people doesn't have to go to MyChart to be able to push the information for the physician to see. And to your first question, how exactly we're pulling the information. So imagine that you have account in Parkland or in Children or any other hospital. So you enter this account information in our system, and our system downloads all the health information from there. You have school portal information. You enter this school portal information in our system, and our system downloads all of the school-related information in our system by creating a new profile. And after that, what our system does is combining all of the profiles for a single person into one summary, which is called executive summary. And we also noticed that in many cases, the vaccination information, it is inside of the school system. In many cases, the physicians doesn't have access and visibility to vaccination information, but this is something which is very present in the school records, and also different examinations and so on.
Exactly. So we can pull data of any sorts, like Ivilo is saying, put it in a data dump, and then have an overlaying, organizing database that will pull the data and put it together so the patients or the users can share them.
Yeah, we created state-of-art AI, which is doing this summary.
Thank you. I'm going to go ahead, Liz. If we have time, we'll come back, but let's go move on to Ed.
Hi, thanks again for a great presentation. My questions really have to do just to make sure I understand what is happening now, like what you're able to do now. And so, for example, the presentation seems like you're supporting ADHD use cases, ADHD, also asthma, also COVID, and then sort of varying levels of EHR integration, but also some, cutting edge things like risk prediction. Can you just clarify, are those types of functionalities and tools available across all the use cases, or what's actually, what are you able to do now for say ADHD versus COVID versus asthma? Do you know what I mean?
No, I do understand. So truly the platform is the users to use as they see fit. So for instance, for asthma, what we're doing with the Fort Worth ISD is just to pull diagnosis data, analyze them, sort them out, and identify those kids with asthma, prepare a report, and show them, hey, these are the kids in your school that appear to have asthma based on their EHR. Prior to we doing that, 10% only of people would actually report a diagnosis of asthma. Now they can have a wider case identification. So it's truly fairly, let's say, basic, pulling data, sorting it out, and sending it out. Same thing with ADHD. If they want us to send them ADHD data, exactly the same deal. We pull the diagnosis, we identify those diagnoses using, typically ICD codes, name, word recognition, and then send it to them. But then when it comes to the COVID report, it was really a special request from them. What they wanted to get from us was, is it possible, given our patient, that some of our patients are on your platform, for you to give us a sense of how we deal with these patient populations during the COVID-19 pandemic. So we got a data scientist, he's on the line, Roland, on the case, and his role here was to help us figure out a way of identifying those hot spots, because school districts are going to either open or close based on whether they're in a hot spot and whether they're having a lot of sick children. So we pulled the data from MyPHI, and then we found this Facebook survey symptoms tracker that actually identifies hotspots even before people start showing up in the health system. And the MyPHI data and the school and the Facebook data put together help us sort out those patients into, okay, if you have asthma and you're in a hot spot for COVID, this is a high risk. If you have ADHD, well, and you're in hotspot, they might have to send you online, which means you need to be, the nurse needs to reach out to you. But it really was just to help them organize their COVID response using our data from MyPHI and additional data analysis that we put on top of it.
So just imagine that our system pulls information from different sources. So we pull information from the hospitals, from schools, we also pull information from the social media. And after that, we combine all this information and we can run reports on the top of that. We can say how many patients have HDD, how many patients have asthma. And also we're extracting all the zip codes associated to certain person by using their hospitals and school profiles to say what is the risk score of COVID inside of this zip code. And we're sharing this with Fort Worth ISD as well.
Thank you.
Thank you. Thank you for the presentation and the questions and answers. Let's move on to CareMap.
Thank you, Dr. Mann. The CareMap team, composed of partners from Family Voices, Duke Health, and Boston Children's Hospital, first want to acknowledge the tremendous support and the inspiration from the Maternal Child Health Bureau's Grand Challenge. The team members are listed here. Particularly want to do a note of gratitude to Dr. Alex Kemper, our mentor. Let's go to the next slide, please.
Good afternoon. I'm not using mute very well or unmute, so that's not a way to start us off. My name is Kara Coleman, and I'm going to start this part of our demo with the foundation of the CareMap app, with the actual name originating from the original CareMap, as pictured here on the left, created by Kristen Lind, who is a family caregiver from Boston Children's, and she literally sat down at Dr. Antonelli's kitchen table and tried to illustrate exactly who was involved and what was involved, and the supplies and the systems and the communication and the care coordination that was desperately needed in the ecosystem of care for her son. And that is what forms the essence and the foundation of the solution that we'll present to you today in the CareMap app pictured here on the right. Next slide, please. I would like to introduce you to Miss Isabella, who is the precocious 9-year-old that we've created for the simulation that will demonstrate our app. She's the oldest of 3 children. As you can see, she's quite a doting older sister holding her younger sister's hand there. She has a younger sister and a younger brother. She has a mother and father, however, they're divorced at the time, so she's splitting time between 2 households, which kind of creates a larger community for her as well. She lives in a rural community, very strongly vested in the community in terms of supports, as well as her connection to church and other families. And the rural aspect of it has created some challenges for her in terms of accessing healthcare, but also accessing learning in this time of COVID and distance learning. She's in 4th grade. This young lady loves to be active, misses her school and her recess and PE time, but still finds time to ride bikes and scooters with her little siblings. In between that, she is still getting some therapies through distance learning. She's getting cognitive behavioral therapy and occupational therapy, and her favorite, music therapy. She's learning outside of music therapy to play the piano and then using that to help her deal with her ADHD and what we think may be some generalized anxiety disorders. She does have a diagnosis, as I said, of ADHD. But she's having some bladder and bowel issues right now that the school psychologist, the school nurse, the teachers, GI, urology, the primary care provider are all kind of thinking in different sort of silos that perhaps there's some more going on and that maybe it's generalized anxiety disorder. And so in the next few slides, you're going to see the ways in which all of these people can actively communicate and coordinate care to help Isabella figure out what the diagnosis is and what the solution is going forward. And I'll pass off to my colleague, Dr. Ming.
Thanks. As a personal health record that's accessible anywhere and anytime, CareMap keeps information organized and updated for patients and families like Isabella's, thereby shifting the locus of control back into the hands of patients and families. Examples of key elements that are being shown in this video include a medical overview that provides a high-level medical snapshot of the key health needs facing the child, a list of their key health conditions, patient-centered care goals, both for the short-term and the long-term, as well as practical emergency care guidance that provides a what to do if type situation reference for patients, families, and providers. There's also information about prescription medications that are linked with the EHR. In addition to these sort of structured sections where you can capture information, CareMap also has the ability to provide personalization of the content. So in this snapshot, you can see a family member inputting an additional prescription medication that was left off to the list from the EHR med list, with spaces for flagging and notes that can then be later shared with the care team. Because CareMap is connected to the EHR using open standards, then information can be bidirectionally transmitted between CareMap and the EHR. Though many apps are increasingly able to integrate with EHRs, we believe CareMap is uniquely positioned to harmonize EHR data along with parent-reported insights to generate a comprehensive, holistic overview of the child's healthcare needs. Tracking goals is an example of how CareMap balances standardization and customization. In addition to a selection of standardized, commonly reported symptoms and goals, such as pain, sleep, and mood, CareMap also allows patient-specific, customized care goals to be entered. In this example, we saw a family member entering a custom care goal focused on daily adherence to a critical medication for our patient, Isabella, thereby allowing CareMap to highlight the care goals that matter most to patients and their families. And when you bring together those custom care goals with the standardized care goals in this central tracking section that you're seeing here, it provides a comprehensive overview of the patient's progress over time. The data visualizations that result can generate trends and insights that can provide data-driven, direct, and timely feedback back to patients and families. And those same insights can be transparently shared and communicated in a proactive manner with their providers, therefore functioning as an information bridge between patients, providers, and ultimately enhancing access to care. Finally, the ability to directly share this type of information with providers, the insights that are gathered directly by patients and families over time in their homes, is a particularly unique feature of CareMap. Here we saw the care plan being shared directly with the patient's school nurse. And by facilitating this type of information sharing, CareMap facilitates integration of the entire care ecosystem. The summary care plan and key insights, as shown in the video on the right, and the provider dashboard on the left, are also directly visible in the EHR to providers. The information on that dashboard then becomes a powerful resource to facilitate clinical decision-making, because it makes visible many healthcare insights and patterns that are currently invisible to providers during routine clinical encounters.
Thank you. My name's Casey. Our team's goal for phase 3 was really to confirm that the CareMap could actually support the needs of families of children and youth with special healthcare needs and ensure to get a actual review from a broad range of perspectives. Our initial plan was to test the app out with BCH and Duke patients in a clinical setting, but we pivoted due to a simulation due to COVID. Through leveraging our Family Voices partnership, we recruited 38 participants from 19 states, all who interacted as if they were our simulated Isabella's parents. In terms of getting feedback, we used the validated Pediatric Integrated Care Survey to measure the experience of care integration. We also implemented the user version of the Mobile Application Rating Scale, UMARS, instrument to assess the quality of the app. I'm pleased to report we got an average score of 4.1 out of 5 on our PICS and a 4.0 out of 5 on our UMARS scores. We found that CareMap actually doubles the likelihood that families can track their long-term care goals, and that it increased the knowledge for participants of what's actually possible when it comes to coordinating their child's care. Finally, to address equity, we engaged with a family liaison for Spanish-speaking families. She relayed that families need much more than just translation of the information, and instead to look for opportunities to automate the data tracking or simplify the data tracking where possible, to put time into making resources such as tutorial or multilingual user support, and finally just look at the design from a non-Western lens, such as simple components like adding name fields so that users can actually communicate the entire name of their child. Next slide.
So as we begin to think about how to scale CareMap beyond this simulation, the first thing we think about is how many Isabellas are there in this country? There's 13.6 US children who have special healthcare needs, 5.1 of which are Black and Latinx. And then we can even think about the usability of this in terms of active communication that Dr. Ming demonstrated and coordination that the app was showing could also be used very easily with the 27.2 US adults who have multiple chronic conditions as well.
And we're proud of the fact that this is a family-held and family based solution for care coordination for kids with special health care needs, but there's other pathways to scale that we're actually very excited about. One is health systems. We can imagine health systems deploying the use of the care map, if you will. Actually writing a prescription for an app could become a performance measure for a delivery system with a focus on children and youth with special health care needs. That would be especially relevant for Medicaid accountable care organizations and commercial value-based arrangements. We also see that insurers could offer access to care map as a tool to enable their members, their customers, if you will, an approach to effectively engage members of the care team, especially for children with complex needs. And then finally, the families themselves. As has often happened across the United States, including way back in the day with medical homes, starting with the notion of what do families need, and having the families promote this app as an element of what they consider to be equitable, high-value care would be another pathway to access. Next slide.
So many potential opportunities to support so many Isabellas and their adult counterparts who also have special health needs. We're excited to take the next steps to try to improve upon what we've developed in these phases of the Demo Days Challenge. First, we anticipate systematically assessing CareMap's full functionality by conducting robust clinical research to evaluate the impact on health outcomes and leveraging methods such as hybrid implementation and pragmatic trial designs to be able to better understand real-world barriers to barriers and facilitators to real-world implementation. We know that there's multiple clinics in our institutions who are on standby and eager to deploy this type of a solution with their patients, including our sickle cell population, our cystic fibrosis clinics, primary care, neurodevelopmental pediatrics, as well as several adult clinics, inclusive of geriatrics and lung transplant here at Duke. Because of our institution's existing infrastructure and our existing adoption of FHIR open standards, we believe we are well positioned, along with our strong national partnerships with Family Voices, to be able to move forward with clinical research that's both pragmatic and focused on the outcomes that matter most to patients and families.
Also, as per feedback from patient family partners and other stakeholders, we plan to improve the in-app experience and features like tracking multiple siblings, having multiple caregiver access, improved real-time communication options, and also enhancing the insights into patients' health. We also understand that CareMap is one of the key tools in a growing field of digital health interventions, and we plan to leverage open standards to integrate with such patient health solutions, building connections with chronic disease management tools, mental health apps, secure messaging solutions, and patient portals. We want to create technical linkages to community-based social software solutions, such as around housing, food, and education.
And so it's with great intentionality that we began, grounded in the foundation of the original care map created by families for families to connect to providers and systems and professionals across the ecosystem, that we end our next steps with Isabella and the 13.6 million like her and the millions of adults with chronic care, to focus on the next steps really needing and pivoting to providing more value to families. What else is needed? How can we expand? Listening to what we learned in this simulation and moving forward, and always keeping in mind in that next step forward, ensuring equitable access to whatever solution comes from the next step. Thank you.
Thank you very much. Now let's move on to questions and answers, and we'll start with Liz.
Hi there. My question is really around trying to better understand. I was reflecting back on the care plan screen, and the I guess buckets of information that were on there were kind of generalized, and I wondered if you could elaborate how because you had mentioned, I guess in the case for Isabella, that she might have a variety of different specialists who might be evaluating her to get to a diagnosis, right? So I wondered then how the integration, how that was going to work, and then also then, maybe there's, let's say, adjustments to the care plan that any one given specialist might have. If you could talk through the workflow there, that would be great.
Elizabeth, this is Rich Antonelli. Let me just make sure that I understand the question. You're presuming, you're asking about multiple members of the care team and how does the app actually allow integration? Okay. All right, I have that. Nitin, why don't you go first and then I can follow up if there's a clinical lens we need to add.
Yeah, I'll take the technical from my perspective. So what we're doing is the ability to using open standards like FHIR and access to the patient's own health data. So the care plan brings in information across all the different specialists together and in patient's own hands. So it's a patient's own personal health record. It is, we're not trying to kind of replicate what is in the patient portals, but what is more timely, real-time, actionable that is needed for the patient. So it's aggregating information across all the different health systems that patient may be seeing in different specialists, primary care that they're going to. In addition, in terms of the two-way nature of this is that all that aggregated health information is also available to the specialists as well. So not only like they have access to their own notes and information, but also across other health, the broader health system, including what the patient themselves are also tracking and flagging for their care team.
And I'll add on an important aspect of this. So what we know about children and youth with special health care needs, and in particular, we chose Isabella because she has medical, behavioral, educational, and access transportational challenges. Many of these families find a link. Often they have to identify it themselves as what they call the integrator, the sort of single point of entry into the system. And so the way CareMap would be deployed would be, there would be an understanding that for the behavioral piece, this will be the consulting psychologist, for example, or for the medical piece, it'll be the medical home provider with the PCP. So the family has the ability to enlist members of the care team across disciplines, and those information flows and data flows that you've seen would actually be relevant for each of the members of the care team. Hence, it's not just a care coordination tool, but you put your finger on the heart of this tool. It actually is around integration across disciplines and across settings.
Let's move on to Ed. And I would suggest to the teams that try to keep your answers short because we have a lot of questions and want to get to all of them. So Ed?
Yeah, thank you. Again, a great presentation. My question is sort of similar. If I understood correctly, the sim used simulated data, and then you use that to sort of interview and ask for feedback from patients. Around this FHIR standards, can you give us some insight around your confidence level around those data elements are going to be available through your EHR, the specific FHIR resources available to drive that portal, that view that you're showing?
Yes, so actually we are integrating, even in the sim, we leveraged a simulated patient from one of the health systems. So it is pulling all the different pieces that we demonstrated in CareMap are being pulled from healthcare systems. And again, in all major healthcare providers have, our solutions have expanded, continue to expand kind of more and more kind of data that is available through FHIR. So we are fairly confident that we're able to kind of present a full picture to patients.
I'll also add on very briefly from the Duke institutional perspective that we've had discussions with our technical systems that the functionality we've demonstrated in terms of the FHIR access and the visibility is feasible kind of today with existing technologies and plugins that we have active with other type products within our health system.
Thank you.
Thank you. Tom?
Yeah, I have a lot of questions. I'm excited. I worked on the CMS interoperability, so I'm very, very happy to see the open access FHIR adoption. Probably something, and I don't think you have an answer because a lot of people are trying to figure this out. But I wrote the payer-to-payer portion on your record following you from payer to payer, and I'm really wondering how you're thinking of dealing with like error reconciliation and who is right, who is wrong. Because I haven't figured it out. Like we haven't figured it out. But I'm really curious what you came up with.
Yeah, no, that's actually great. Great question. Because the source of truth in terms of is it the kind of patient who ends up being reconciling the data? Is it oh, sorry, Tom, you seem to be unmuted. Okay. Oh, okay. I'll continue. So what we're doing is, we are using a partner with another healthcare integrator called One Up Health, and what we're able to do is to track for each and every integration that the patient would have for the healthcare system. We are able to flag that this, so say this list of medications are from the specialist, and these additional medications are from your primary care, and if they conflict, it's the patient who's we are kind of putting it in, we're kind of making it transparent to them. Certainly there are challenges in terms of automatically trying to reconcile different elements. That is definitely in our kind of roadmap to figure out like how we can do it and make it available. But for now, the approach we're taking, we're making it transparent for the patient's family to have this broader access, and then they can really kind of like take ownership and flag it for the care team.
Okay, thank you.
We have 1 minute. Is there any questions that can be answered in a minute? If not,
Marie, can I ask what? I think it's a quick question.
Okay.
The measures you're using around symptom checking so far, I assume those are evidence-based validated instruments like PROMIS or something like that?
For the patient experience, is that what you said, Ed?
Yeah, there were you showed some screens around the getting patient data, almost like patient-reported outcome type of data. I just wanted to ask around the evidence base for those instruments.
Yeah, the evidence-based, so it's the Pediatric Integrated Care Survey is validated, and it's in use across the US. It's actually in use on 3 other continents as well. So it's a validated instrument. Some Medicaid programs are actually already using questions from the so-called PICS instrument in their ACO contracts as well. It's a companion, it's not the same, but it's related to the Family Experience of Coordinated Care measure, which is National Quality Forum endorsed. So there's really just 2 patient reported outcomes that are validated on the national stage that would be relevant for this one. Because we thought of CareMap as an integration tool, not just simply as a care coordination tool, but as an integration tool, we decided to look at our PICS standards. And as Casey reported, we've got lots of clinics that we've done without using a CareMap app, and we double the rate of family experience of integration for long-term goal tracking with the CareMap.
Okay, sorry, Marie, I think there's a little longer, but my question was a little bit different, but that's okay, thanks.
You're on mute, Marie.
But anyway, thanks to Boston and Duke team. Let's move on to Montana.
Hi, I'm Sarah Halexa, and this is my colleague Marty Blair. We'll be joined during the Q&A by Chelsea Bodner. We're thrilled to be with you, and welcome to Montana. After 101 days in the hospital, Timothy is heading home to his small frontier town in eastern Montana. His mom has been through this before, and she knows what works best to support his complex care in day-to-day and urgent situations. Fortunately for Timothy and his family and his local healthcare providers, he goes home with an NP2 to support this critical transition. They all have access to his cloud-based care plan, his NP2. It succinctly summarizes his current medical information and his preferences on how to approach his care.
Timothy's family shaped it, and his primary care provider reviewed and completed it with them. But even better, a collaborative of pediatricians from several health systems have access to his MP2 and are ready to support Timothy's urgent or emergent care should he need it. The Montana Pediatrics Medical Passport, or MP2, supports focused communication between families and providers. It ensures safe handoffs and continuity of care, and it's embedded within a telemedicine platform for use anytime, anywhere.
Over this last year, the MP2 really has come alive. Families and providers are very excited to scale this unique family empowerment tool of the future. Family Voice guides our development, an innovative provider collaboration uses and supports the product, and healthcare systems and payers are actively encouraging widespread adoption in their market. During phase 3, the MP2 development team engaged in 65 interactive design sessions and 23 in-depth feature reviews. User experience and workflow improvements were suggested by families, medical home primary care providers, and healthcare specialists. And after their first MP2 encounter, 89% of families agreed that MP2 process was reasonable, time efficient, and made important information easy to find. Following the MP2 review with their healthcare provider, 96% of families said that MP2 made it easy for them to communicate their child's needs with the provider, and 97% said MP2 met their expectations. We established a highly responsive development culture that values clear and detailed user feedback. We continue to ensure that MP2 exceeds family and provider expectations.
We heard, we translated, and adopted user suggestions into platform improvements over several months of iterative design sprints. Family-driven feedback focused on workflow, feature adaptations, data integrity, care plan ownership, and user interface. We've been fortunate to travel the development journey alongside those who use and need this tool. The Montana children with complex health needs and their families who now have active MP2s represent children with inborn errors of metabolism, with inflammatory bowel disease, technology dependence, pulmonary disease, and many other special healthcare needs. Their various and changing needs inform our design roadmap. We understood early on that our success was directly tied to our ability to simultaneously push the norms of provider-family communication, to engage payment systems, and to involve healthcare providers as users, adopters, and promoters.
Even before the recent explosion of telemedicine, and out of respect for our vast geography and the need to meet families where they are, literally, we decided that care coordination and shared care planning must be embedded in telemedicine capabilities. This integrated model opened the door to health IT design expertise, to greater potential for health system funding, and to an existing healthcare delivery mechanism outside of a sole payer system. Currently, over 60% of Montana pediatricians have a login to the Ahana Health telemedicine platform and can access MP2 shared care plans. More importantly, this powerhouse collaboration has demonstrated scalability to remote communities and special populations.
For example, just this past July, our Associated Provider Collaborative partnered with school-based nurses on the Fort Peck Indian Reservation. Using telemedicine, this partnership provides continuous care to children and families who face tremendous health and transportation barriers. We will soon integrate telepsychiatry and behavioral health. It is the MP2 that delivers patient and family-centered continuity of care to a remote setting that would otherwise use 4 separate, non-integrated EHR systems. MP2 supports NICU graduates at discharge so that they and their families who live in distant communities can benefit from telemedicine. Their local and urgent care providers can access MP2 anytime it's needed. Initial feedback from these families indicates that MP2 has reduced unnecessary, distant, and costly emergency department visits and readmissions. Newly diagnosed diabetic children are leaving the hospital with MP2 so that families can be followed post-discharge, supported with sick day management, and have early and timely assessments from home to avoid costly emergency department visits. Each of these MP2 uses teaches us how to make it better, But most importantly, families like it because our solution is specific to caregiver and provider needs. It is fit for purpose.
Our development partnership goes beyond users. Payers as well as patient advocacy organizations support NP2. How so? Well, since HRSA's investment last year, Montana Title V and Mountain States Regional Genetic Network invested a combined $54,000 to support direct family involvement in the NP2 design and testing. Furthermore, this was followed by a $400,000 investment by the Healthcare Service Corporation, the parent company of Blue Cross Blue Shield of Montana, Texas, Oklahoma, Wyoming, and New Mexico. HCSC is funding integration of additional remote patient monitoring and direct messaging capabilities to establish care connections between local providers, regional resources, and families.
But we are not done. Our growth and sustainability path includes ongoing discussions with Blue Cross Blue Shield of Montana and Montana Medicaid to leverage the combined strength of pediatric providers, telemedicine, shared care planning, and remote patient monitoring. We need your help to respond to the demonstrated user demand in urban and rural settings. So what's next?
We are harnessing the advantages of the HCSC funding integration with remote patient monitoring. We are solidifying additional funding partnerships with payer and health systems to support provider adoption and use. And we continue to evaluate the ongoing impact on all stakeholders and will strive to demonstrate value by achieving decreased hospital admissions and readmissions, improved access to well-informed and locally driven care, connection of geographically dispersed providers, and most importantly, family-driven, family-empowered outcomes.
Paid use by customers ranging from an urban healthcare system to a school-based tribal health program demonstrates the business viability in our fee-for-service market. But its payer investment in and promotion of NP2 as a care coordination tool and as a means to support value-based healthcare, this is an admirable testament to even greater potential for financial sustainability. Our care coordination approach as a comprehensive model of telemedicine access and shared care planning is key to our accelerated development, testing, and adoption success. It is the value add. In short, we are cracking the code of complex care planning in a unique and highly impactful way.
The return on investment represented by user satisfaction, improved health outcomes, and more efficient healthcare utilization is demonstrated by our investor and customer growth over the last 6 months. Our early design and development decisions set the stage for NP2 to function as a quadruple aim solution. NP2 brought all the necessary stakeholders into our shared space to achieve a better reality and future for children with medical complexity. We have become, for our community, a place where family and provider hopes, dreams, and reality merge. This momentum cannot be lost. Our families want it, our providers are adopting it, our payers value it, and our health systems are participating in it. Help us take the next step. Thank you.
Thank you. Let's start with Tom. Do you have any questions?
Sorry, one sec. Not really. I think maybe some repeats of the last questions, that I think probably Liz had the same questions on care plans, just because of the sort of nebulous in some of the standards. Very sympathetic to this. My daughter, who's right over there, was in the NICU for 100 days. Also came home on an NG tube. So yeah, that would have been helpful on like home oxygen and complicated, sort of care coordination needs. So it was a sort of a slam dunk seeing the use case for me. But yeah, just sort of, I guess, maybe if you could opine a bit on your thoughts on the maturity of some of the care plan standards and sort of where they were helpful and where they need work.
Am I good? Okay. Yeah, I think we've learned quite a bit over this NP2 challenge, and one thing that's been not only unique to our rural setting, but is how much families need to participate in what providers are interfacing with. And I think we all share similar sentiments that families know quite a bit about their children, and the opportunity to be able to share that in an emergent situation improves patient outcomes and family experience. But more importantly, what we've learned over this phase 3 is how much appreciation the families have for the opportunity to participate in something that is used by providers. And during this phase 3, we really focused on the workflow between the medical home, specialists, and family engagement, with the goal of, in the future, working so that EMS and ED providers can also see that information and directly implement what family-guided care is.
Liz?
Yeah, I had some questions. I guess more just to better understand, like, you know, I think the world of telehealth is, you know, we're learning a lot right now. And wondering just about how that experience works, a little bit more on like the interaction as between, again, trying to better understand the workflow that you all envision. Like, you know, typically on telehealth and telemedicine visit, like, is it that the provider is documenting in their EHR and the MP2? How does the documentation work, and how is it so it's not burdensome on the, I guess, the provider, so that everything's being documented and that it's a good experience as well for patient and family. So I'm just wondering how that integration works. Like, because typically, like, is there an EHR involved? Are they only documenting into the MP2? You know, and then the family experience.
Yeah, I would say, and Chelsea, please feel free to jump in on this too. You know, I think first and foremost is to have a HIPAA compliant shared space where you can have secure editing and tracked information to ensure validity. And then being able to work on connections both in Epic and in Cerner for that information, so that you are reducing the burden on both ends. I think some of the lessons that we've learned is that sharing health data, going from one EHR to a cloud-based program, it actually really requires health reconciliation. And that's probably the most important part that families experienced was oftentimes what's in the EHR isn't necessarily up to date. So just data aggregation isn't enough. And to have a shared telemedicine moments, meeting families where they're at, to go through their child's care, reconcile, and then have a set care plan was really the simplest approach that we took, and seemed to be effective.
Of course, like just at this moment, my internet started being weird, so I'm flashing my video on and off. I apologize. This is one of the #1 questions that we've grappled with, and I think it's been one of the huge values of having sort of boldly having as many providers at the forefront of this work as we have, because I think if you're not the doctor who's been using the bad problem list your entire life, it's really hard to believe that that good enough data isn't already there and should just be pulled, right? It's really hard to be like, really, you have to retype something? But because we are all doctors who all don't trust our own problem lists, and we are at the forefront of this development, we've been able to boldly say, you know what, for this to be meaningful, for this to change the behavior of the ER doc, when that kid comes in Glendive, Montana, in a litigious environment where this is hard and scary, that information needs to be curated and trustworthy. It needs to be validated, and it needs to be for this purpose. So while we are, you know, to Thomas's question, we maintain a culture of interoperability. We vow to be the best members of our HIE. We're working with our HIE on what fields can be pushed and pulled. We have really boldly said, despite inefficiency, utility for families centers around information that was created for this purpose, and EHRs that were built for billing purposes don't cut it. So we continue to grow towards greater efficient push and pull of the right sort of you know, where does the medications and where is truth going to lie? What is the record of records versus what uniquely still doesn't exist in the world that needs to be created. And the beauty of the telemedicine combination is that it can be done conveniently. It can be billed for. It's a high level visit. And then we've also started working on care coordination codes, which engages the families or engages the providers in a paid encounter and gets us a little bit away from sort of the pure efficiency conversation and more towards the usefulness and meaningful conversation.
Thank you. Let's move on to Ed.
Yeah, thanks again. So my question is pretty much the same as Liz's, and you can use the time, I suppose, to expand on it some more if you'd like. But I was looking for more around exactly how telemedicine is being used. So some of it is, I think, is your workflow, but how exactly is the telemedicine actually improving either what's in the care plan or whether people are accessing it or whether it's the content, or just help me understand exactly how the telemedicine part is actually making the care plan itself better.
You want me to go, Sarah, or you want to go? I'm kind of yelling and ranting and I'm probably breaking up. It's probably not a good thing. So the telemedicine touches the MP2 in a lot of ways and vice versa, actually. Like in this, you know, we found that it's not just telemedicine that makes the MP2 better, it's MP2 that makes telemedicine better. And that's part of our drive for equity, because one of the things that underlies our team's mission, motivation, and passion is how do we serve families with medical complexity in the most convenient ways, right? We are all here because we understand that convenient information, well synthesized information doesn't exist. But the other piece is that we are within context, and the context we're within is an entire environment of telemedicine, even pre-COVID, and convenience revolution, sort of things happening, and it is leaving out the families whose lives most depend upon the ability to conveniently touch base about their children. So concretely, we felt like you can't just introduce care planning and have better information if you don't introduce better connections and if you cross geographies and transcend boundaries. So concretely, the care plan lives within the telemedicine context. It can obviously be used not in a telemedicine context. You walk into an emergency room and you have your care plan, like you can break the glass, you can offer that to the emergency room doctor in person. But what is happening in Montana is the synergy of the telemedicine, which gives the MP2 a billable encounter that's highly convenient. It allows for electronic communication that then can be supplemented with the face-to-face. We use the technology. You can share the screen. So you can, we built that in to make it very convenient for everyone. Because one of the things in EHRs and telemedicine is things can get a little bit convoluted. You're not all seeing the same thing at the same time. We can use an asynchronous form of communication within the quote telemedicine platform, in that when a family requests a change or a subspecialist requests the change, ownership lives with, we decide who the owner of the care plan is, and that information comes in, and then it can be tracked and trended whether or not they responded to that. So that allows an opportunity for documenting the ability that you did care coordination work, which obviously can be done under general supervision, the remote monitoring component that a lot of people have. We're also tying in directly to the provider's office so that providers are engaged in this as well as systems because there is a tracked ability to bill for the time you spent keeping this information up to date. But I think the biggest piece about the telemedicine is not just it allows for a convenient billable encounter, but that it allows for, it allows us to engage our passions around the fact that these are the families who deserve convenience. And when a family with medical complexity shows up in this telemedicine community or seeks care, the MP2 is sitting there for them. And so we don't have to turn them away. We could tell you 10 more stories of families who got convenience care from their home, not for care account creation or care coordination creation, but just because they needed help after hours, and with a degree of complexity that every other convenience care and probably every emergency room outside of 4 cities in Montana would have turned them away. So we feel like it is this empowerment tool that helps our families join the convenience revolution on their side. I don't know, blah, blah, blah. Sarah, sorry, being quiet, go.
Thank you. That was wonderful. So this ends our presentations and the questions and answers. And before everyone leave, again, I just want to say on behalf Maternal and Child Health Bureau and HRSA, how thankful we are for your wonderful work. We heard some wonderful presentation, your pitches today, some great innovations, and certainly we wish we could declare all of you, give you all of your prizes, but we can't. We will only have one winner. But just know that, again, you guys are all winners in our book. And it's been a privilege, definitely for me, to have gotten to know you through our journey. And I have learned tremendous amount about the value of having families be partners in everything we do, and that, in fact, they can, in fact, inform our work and move us forward in healthcare delivery. So thank you, everyone, and good luck, and wish everyone well, and we'll be in touch.
Thank you, Dr. Ma.
Thank you.